Hi everyone, this is Bisto on behalf of Learn Medics. Today we are going to deal with systemic inflammation, the second part of the lecture series of inflammation. So in this module we are going to deal with the fever, the leukocytosis, the left shift of leukocytosis during an inflammation or infection, acute phase reactants like CRP, amyloid A proteins, ferritin, hepcidin, fibrinogen, and lastly the erythrocyte sedimentation rate or ESR. Other than the five cardinal signs of inflammation, that is rubor, color, tumor, dolor, and loss of function, we have number of systemic responses. That is, for example, in the case of GIT inflammation, we have general sickness. So the main reasons for the systemic responses, or the three classical reasons for the systemic responses, are the fever, leukocytosis, or the acute phase reactants. Fever are caused by pyrogens. It increases the cyclooxygenase activity in hypothalamus, that is temperature center. We know that hypothalamus is the temperature center. So the pyrogens increases cyclooxygenase activity in hypothalamus. It also increases prostaglandins in hypothalamus, that is PGE2 alter the temperature set point. PGE2 have a various roles, like PGE2 responsible for the fever and it's also responsible for the pain. The pyrogens are two types, that is endogenous pyrogens or exogenous pyrogens. The exogenous pyrogens that are coming out of the body, like it coming out of the body. For example, in the case of bacteria, we have lipopolysaccharide membrane. So the lipopolysaccharide is coming out of the body, human body. So it's called exogenous pyrogens. And in the case of endogenous pyrogens, we have intraleukotrienes and a tumor necrotic factor like substances that are formed in the body. So it is exogenous pyrogens and endogenous pyrogens. So these are responsible for the fever that is happening during inflammation. So the second thing in the systemic responses to the inflammation is the leukocytosis, or else we can call it the increase in WBC count. So in normal WBC we have 11,000. So in case of an infection in human body, the 11,000 ranges from 15 to 20,000. So for any raging infection like leukemoid reaction or the infection from the Brodadella infection, that is bacteria causing whooping cough, we have an WBC count almost 40 to 1 lakh. So the increase in WBC count is also responsible for the systemic responses of the to the inflammation. So it is regulated by the cytokines. That is, before we discuss about the intraleukotrienes and the tumor necrotic factor, there are cytokines that stimulate the bone marrow cells. The bone marrow cells, it increases the WBC. So for any infection like bacterial infection, we have neutrophilia. That is, amount of neutrophils is increasing. For any viral infection, lymphocytosis occur. That is, lymphocytes amount is increasing. Like it is the component of the WBC. So according to the infection, the raising of the component may be changed. And during the discussion of leukocytosis, we have to mention the very main thing is left shift. It is a normal responses to infection that happens during any diagnostic methods. For like in more bands and neutrophils are formed. Here we can see there is left shift during infection. Like from 10,000 to WBC counts is 10,000 to 17,000, and neutrophils changes from 55 percentage 80 percentage, and bands changes from 5 to 12. So it is a normal response to infection. The third thing that is responsible for the systemic responses to an inflammation is the acute phase reactants. It is a major thing. These acute phase reactants are serum proteins which rises the levels during inflammation, whether it is acute or chronic. The acute phase reactants are mostly produced from the liver. It is a liver productions, and it is synthesis increases by the cytokines, especially the IL-6. IL-6 is very important for the production of acute phase reactants from the liver. And the five major acute phase reactants are CRP. One is CRP. CRP is a reactive protein. We will discuss about it. Serum amyloid proteins, ferritin, hepcidin, and fibrinogen. So these are the major acute phase reactants like we are going to discuss in the case of inflammation. So first one we are going to discuss with the C reactive protein or CRP. As I mentioned, it is produced in the liver. It is a liver synthesis which increases in production due to IL-6 from the macrophages. IL-6 is very important. IL-6 from macrophages, which increases the production of CRP or C-reactive protein. It has some antibacterial property, like it bind to bacterial polysaccharides and which activate the complement system of the immune system of our body. In case of chronic increases in CRP associated with the coronary artery, in coronary artery we have increase in CRP, chronic increase in CRP. So we have several tests for CRP. If CRP increases means there is some infection is going on or some inflammation is going on. We have to understand that during any like examine any blood test report. The second acute phase reactant is the serum amyloid proteins or SAA. It is an apolipoprotein. It have a very important role in many inflammatory responses, which causes the secondary amyloidosis. In case of chronic inflammation condition, SA protein, the serum amyloid A proteins deposit and secondary amyloidosis occurs. Example in the case of rheumatoid arthritis, ankylosing spondylitis, inflammatory bowel disease. So, in the case of joint inflammation, the inflammatory cytokines produced from the liver. So, the serum amyloid is increasing, the amount of serum amyloid increasing, and there is an accumulation of amyloidosis, secondary amyloidosis occurs. The third thing is the ferritin. Ferritin is an iron storage protein. The iron bind to its iron get binds to ferritin and it gets stored in the cells. So the iron stored as intracellular as ferritin and stored in macrophages in liver and bone. The clinical significance for the ferritin is the diagnosis of iron deficiency during infection. Any infection in during an infection we have ferritin deficiency, mean we have the iron deficiency. The next thing is the hepcidin. Hepcidin has some antibacterial property which inhibit the iron transport. Just before we deal with the ferritin, it is an iron storing protein. So it inhibit the ferritin, binds to ferroprotein in enterocytes, liver and macrophages. Iron trapped in cells as ferritin. Iron gets trapped in cells as ferritin, and it contributes to anemia of chronic diseases. It inhibit the iron transport. Iron transport is inhibiting. So it is trapped in the cells as ferritin. Increasing ferritin means we have anemia. Okay. Clearly we can see in this picture that any inflammation is happening. The liver, the hepcidin is increasing, which is inhibiting the here we can inhibit it is inhibiting the iron transport. So it is transported, it is trapped, iron is get trapped in the cells as ferritin, so anemia occur. The last thing is the fibrinogen. Fibrinogen is a clotting factor 1 of the clotting cascade. We will discuss about the fibrinogen in our hematology videos. It promotes the cellular adhesion in platelets and endothelial cells. So in the case of inflammation is increasing, the fibrinogen is also increasing. So these all occur during an inflammation. The last thing we need to be discussed in the systemic inflammation is the erythrocyte sedimentation rate or ESR. It is the rate of an RBC that sediment in test tube. Like if we collect someone blood in a test tube, so it is the time taken to settle all the RBCs that present in test tube in the bottom of the test tube. That is the erythrocyte sedimentation rate or ESR. Normally, for men we have 0 to 22 mm per hour. For women we have 0 to 29 mm per hour. But it is in increases by acute phase reactants inflammation. Means that any inflammation is occur. So the amount of acute phase reactants, that is lot of proteins, is increasing in the blood, which increases the ESR. That means it is faster settle in the bottom of test tube because the proteins are stick together with RBC. The rate of sedimentation of red cells are determined by factors like pro-sedimentation and anti-sedimentation. Pro-sedimentation are the factors that increases the ESR rate, that promotes the sedimentation rate, that is increasing the sedimentation of red cells in the bottom of test tube. These are the acute phase reactants, especially the fibrinogen, stick together with RBCs. They stick together with RBCs and settle in the bottom of test tube faster. So the ESR is increasing for any inflammation because the acute phase reactants are stick together with RBC. The another factor which is against the ESR, which decreases the ESR rate, it is the anti-sedimentation, which is negative charge of RBC put away from sedimentation. That is decreases the ESR. The high levels of acute phase reactants which stick together with RBCs faster the sedimentation and increases the ESR. That happens in a case of any common infection or inflammation. The normal ESR is less than 30, but ESR is also seen that is higher than 100. For example, in the case of in the case of endocarditis, temporal arteritis, polymyalgia, rheumatica, trauma, or after the surgery or malignancy. Another thing we have to remember is in anemia we have higher ESR. It is because the sedimentation of RBC is lower with more RBC. If we have more RBC, the ESR, the sedimentation rate, the ESR going to down because it take lots of time to sediment if we have more RBC. But in the case of anemia, we only have a few number of RBC. So the ESR is high because it take very little time to settle the all amount of RBCs in the test tube. That's why in anemia we have high ESR. There is also a condition like which is the ESR is less than 5, which is in the case of due to low level of fibrinogen or hypofibrinogenemia, or in the case of abnormal RBC shape or sickle cell anemia or polycythemia. It is an opposite to anemia. Polycythemia means the amount of RBCs is increased, hugely increasing. So in these cases we have reduced ESR or less ESR is less than 5. The next thing is against the ESR is the negative APRs. Levels of APRs fall in inflammation. The APR synthesis in liver is inhibited by cytokines. So we have negative APRs which also decreases the ESR rate. So any infection happening in a body, if the acute phase reactants or APC or any proteins stick together to RBC, and it is easily fasterly it will settle down in the bottom of the test tube, so the ESR rate is increased. So that's why when any infection happening to a person and we just randomly during some blood serum test and we keeping on the report we have high ESR, high CRP, which is due to these acute phase reactants. So remember that. That's all about the systemic inflammation. So thank you guys.